Good day everyone. So our group will be presenting on Lyme disease. I am Ameera Aldam and together with me are Kylie Bernardino, Faith Climaco and Angel Delos Santos. We will be presenting the characteristics of Lyme disease, a short run-through of its etiology and epidemiology, signs and symptoms of the disease, characteristics of the organism, stages of the disease, laboratory diagnosis, diagnostic evaluation, treatment, and prevention of Lyme disease. So, what is Lyme disease? Lyme disease, also known as borreliosis, is caused by the spirochete Borrelia burgdorferi, which is transmitted primarily through the bite of infected ticks. It is classified as an emerging infectious disease influenced heavily by environmental and socioeconomic changes, such as farmland being transformed into suburban wooded areas, which are ideal habitats for deer and ticks. In the United States, the disease typically begins with a distinctive skin lesion known as erythema chronicum migrans or ECM, which slowly expands from the site of the tick bite. This occurs in about 60 to 80% of cases. Lyme disease is a multisystem illness affecting the skin, joints, nervous system, and heart. It often begins in the summer months, accompanied by flu-like symptoms, and evolves through different stages if left untreated. For the historical background, Lyme disease was first described in 1975 in Old Lyme, Connecticut, wherein clustered cases of juvenile arthritis appeared in a rural area. Two mothers noticed the pattern and reported it to the health officials. The condition was initially termed Lyme arthritis. Its epidemiological features suggested arthropod vector transmission. In 1982, the causative agent was isolated and identified as a new spirochete, named Borrelia burgdorferi after Willy Burgdorfer, who co-authored its discovery. Clinical features were soon recognized to extend beyond arthritis, confirming it as a multisystem disease. As for its current threats, Lyme disease is the most common vector-borne disease in the United States. In 2013, over 36,307 confirmed or probable cases were reported. The number of reported cases has doubled since 1991. According to the CDC, this increase reflects a true rise in disease frequency and improved recognition and reporting. So next, we have the etiology of Lyme disease. The causative agent is the Borrelia burgdorferi, a spirochete first isolated in 1982 by Burgdorfer and Barbour. Lyme disease is a cutaneous systemic infection transmitted by hard-bodied ixoid ticks. There are three main pathogenic species. We have the Borrelia burgdorferi, which is predominant in the United States, the Borrelia apzelli, mainly in Europe and linked to acrodermatitis chronica atropicans or ACA. And lastly, we have the Borrelia garini, found in Europe and Asia, and it is associated with neurologic symptoms. As for its vectors, we have the Ixodes scapularis, the Ixodes pacificus, the Ixodes ricinus, and the Ixodes persulcatus. For the reservoirs and host, we have the white-footed mouse or Peromyscus leucopus, which is the primary host for tick larvae or nymphs. And we also have the white-tailed deer, which is the host for adult ticks, and it is crucial for tick survival but not part of spirochete life cycle. Domestic animals such as dogs, horses, and cattle can develop clinical Lyme disease. Human infection risk depends on local tick infection rates and probability of transmission from bite. Certain HLA types, such as HLA-DR4 and HLA-DR2, may increase risk for chronic Lyme arthritis. The spread is influenced by environmental changes, And ticks may enter homes via pets, though pets are unlikely to transmit the disease directly to humans. For the epidemiology of Lyme disease, its global presence has been reported on all continents except Antarctica. It is the most common vector-borne illness in the United States, which accounts for 95% of such cases. It is also recognized as a major health hazard for both humans and domestic animals. As for its geographic concentration, it is primarily in the northeast and upper Midwest regions of the US, and in areas with high incidence are expanding geographically. Now let us discuss the signs and symptoms of Lyme disease. So the general characteristics of Lyme disease is that it may be transitory or chronic, with some cases becoming severely disabling. Accurate diagnosis is crucial but complicated by overlapping symptoms with conditions like chronic fatigue syndrome and fibromyalgia. Multisystem illness involves skin, nervous system, heart, joints, and immune system. It typically begins in summer with erythema chronicum migrans or ECM and flu-like symptoms. Lyme disease presents in three general stages, though these often overlap. For stage 1, we have the early localized infection, where it begins days to weeks after the tick bite and is characterized by erythema chronicum migrans, a red expanding rash, and flu-like symptoms such as fever, fatigue, and muscle aches. For stage 2, we have the early disseminated disease. Weeks to months later, untreated cases may develop cardiac issues like heart block or myocarditis, neurologic symptoms including meningitis, cranial nerve palsies, and radiculoneuritis. For stage 3, or the late disease, months to years later, chronic manifestations can include Lyme arthritis, often affecting large joints, and neurologic deficits such as memory issues, neuropathy, and encephalopathy. So Lyme disease also presents cutaneous manifestations. As mentioned earlier, we have the erythema chronicum migrans or the ECM, which is an expanding red skin lesion at the tick bite site. Initial red papule most often appears on thigh, groin, or axilla. ECM is more frequently seen on the face of children. Secondary lesions develop in 50% of untreated patients. Borrelia lymphocytoma, which is a rare tumor-like swelling on the earlobe or nipple, may resemble lymphoma. Acrodermatitis chronica atrophicans is the late-stage skin condition more common in Europe. Its features are bluish-red discoloration, fibrotic nodules, skin atrophy, and associated polyneuropathy. We also have musculoskeletal manifestations. So arthralgia and myalgia are early features. Frank arthritis is uncommon during early ECM, but common months to years after infection. And 25% of its patients develop Lyme arthritis, sometimes as the only symptom. Chronic Lyme arthritis involves persistent joint infiltration by spirochetes and local inflammation. Parvovirus B19 may cause similar arthritis symptoms and overlap during certain seasons. Third, we have the neurologic manifestations. So this occurs in 15% of untreated patients, typically 2 to 8 weeks after onset. Early symptoms are septic meningitis, cranial nerve palsies, radiculoneuritis, and peripheral neuropathy. Late symptoms are chronic encephalopathy, polyneuropathy, leukoencephalitis. It is manifested as memory loss, mood changes, sleep disturbances, fatigue, hearing loss, and verbal memory issues. CSF may show elevated protein and intrathecal antibody production. Its ocular signs are optic neuritis, cranial nerve palsies, panophthalmitis, choroiditis with retinal detachment. As for its cardiac manifestations, it affects 8% of untreated patients, typically 1 week to 7 months after infection. Its common signs are atrioventricular or AV conduction blocks, bundle branch or fascicular blocks, tachyarrhythmias, myopericarditis, rarely congestive heart failure, and its symptoms are lightheadedness, syncope, dyspnea, palpitations, and chest pain. Usually mild and self-limiting but may require temporary pacing. Next, we have pregnancy. So transplacental transmission of Borrelia burgdorferi is confirmed, and there is no consistent pattern of congenital malformations identified. Some reported fetal deaths linked to first trimester infection and inadequate treatment. Lastly, we have immunologic manifestations. Cellular immune response begins early, followed by humoral response. The early responses are increased suppressor cell activity and decreased NK cell activity. IgM appears first, then IgG, which is usually after 2 to 4 weeks. Antibodies may persist for years post-treatment, and high IgM titers in early disease, especially against flagellar 41-KDA protein. Outer surface protein A antibodies develop in some chronic arthritis cases. Immune complexes, cryoglobulins, and anticardiolipin antibodies may be present. Synovial inflammation in Lyme arthritis linked to interleukin-1 mediated cartilage or bone erosion.
We will now proceed to the characteristics of Borrelia and Lyme disease. We will delve into the causative agents, their morphological features, transmission dynamics, and more. To begin, this genus comprises several species that are responsible for Lyme disease. In North America, the primary culprit is Borrelia burgdorferi. However, in Europe, Lyme disease can be attributed to multiple species, including Borrelia afzeli and Borrelia garini. For the morphological characteristics, Borrelia exhibits distinct morphological characteristics. It is a loosely coiled spirochete, generally measuring between 5 to 25 mm in length and 0.2 to 0.5 mm in diameter. One of its notable features is the highly fluid outer membrane, which is composed of glycolipids and proteins. Additionally, Borrelia contains significant lipoprotein antigens, ranging from OSPA to OSPF, which are encoded by plasmids. Moving on to the flagellal structure, Borrelia possesses 7 to 11 endoflagella, also known as periplasmic flagella, which run parallel to its axis. These flagella are made up of 41 KDA subunits that provoke a strong antibody response, making them significant for diagnostic purposes. However, it's important to note that cross-reactivity with other spirochetes can lead to false positive in serological testing, complicating the diagnosis of Lyme disease. Next is the growth and culturing. Borrelia reproduces through binary fission, typically every 12 hours. Culturing this organism can be performed in Barbour's toner Kelly medium at a temperature of 33 degrees Celsius. However, isolation from patients poses a challenge. It is also noteworthy that spirochetemia, the presence of spirochetes in the blood, tends to be short-lived and is primarily detected early in the course of the illness. Next, let's discuss the reservoirs and vectors of Borrelia. The main reservoir for this bacteria is the white-footed mouse, known scientifically as Perimyscus leucopus. In regions like California and Oregon, the dusky-footed wood rat also serves as a reservoir. The primary vectors for Lyme disease transmission are Ixodes ticks. Typically, we have Ixodes scapularis in the northeast and midwest U.S., Ixodes pacificus in the west, Ixodes racinus in Europe, and Ixodes persulcatus in Asia. Next is the transmission dynamics. Adult ticks primarily feed on white-tailed deer, which play a role in the life cycle of Borrelia. Both nymphs and adult ticks are capable of transmitting Lyme disease. Notably, feeding peaks occur in late spring, early summer, and fall, which aligns with the typical occurrence of Lyme disease during these periods. It is essential to note that the risk of transmission is low if ticks have fed for less than 36 hours rather. With some studies suggesting that the risk remains low even after 72 hours. Moving on to the stages of Lyme disease, the first stage of Lyme disease is marked by localized rash known as erythema migrans or EM. This rash typically appears within 2 days to 2 weeks after a tick bite. It starts as a small red papule at the site of the bite and can expand into a larger ring-like erythema. A critical aspect of diagnosis is recognizing this rash, which should be at least 5 cm in diameter. At this point, patients might be asymptomatic or experience mild flu-like symptoms. Following the localized rash, early dissemination occurs through the bloodstream within days to weeks. This can affect various organ systems, including the skin, nervous systems, heart, and joints. Approximately 10% to 15% of patients may present with multiple skin lesions. Symptoms during this stage often include migratory pain in joints and muscles, as well as potential neurological complications such as facial palsy or even a septic meningitis. The final stage of Lyme disease, known as late disseminated disease, can develop in untreated patients months or even years after the initial infection. The most significant manifestation at this stage include arthritis, peripheral neuropathy, and encephalomyelitis. While conventional antibiotic treatment are usually effective, some patients may experience treatment resistant to arthritis. Even after treatment, a small percentage of patients may continue to experience cognitive difficulties and musculoskeletal pain. These symptoms can last for over 6 months in some cases, highlighting the need for ongoing research and understanding of Lyme disease.
Good day everyone, I am Delos Santos, and now let's move on to the diagnostic evaluation of Lyme disease. So first, we have to know the history of the patient if they got any exposure to tick, so information about potential tick bites or exposure in endemic areas. And also the symptoms, so in early signs, it can include erythema migrans or a characteristic of skin rash. We also have flu-like symptoms like fever, chills, fatigue, muscle and joint aches. And then later stage symptoms, if left untreated, Lyme disease can lead to neurological symptoms such as meningitis, radiculopathy, Bell's palsy, and cardiac symptoms like Lyme carditis, heart block. Also, joint symptoms such as Lyme arthritis. According to the Center of Disease Control and Prevention, or the CDC, they actually recommend a 2-step serological process for diagnosing Lyme disease, involving an initial enzyme immunoassay or the EIA and a confirmatory Western blot test. So, a negative result in the first step negates the need for further testing, while positive or indeterminate results require the second step. So it's important to consider that serological assays can miss recent infections, as antibodies may take weeks to develop. Additionally, elevated antibody levels can persist long after the infection. Cross-reactivity with other conditions can yield false positives, and results for IgM antibodies should not be emphasized if symptoms have lasted over 30 days. Ultimately, any alternative test must receive FDA clearance prior to CDC recommendation. The enzyme immunoassay, or the EIA, it is the initial testing. So this test detects antibodies like IgM and IgG against the Borrelia burgdorferi. So the interpretation of the EIA, if the result comes negative, it is typically indicates that Lyme disease is unlikely and no further testing is usually necessary. So if the result comes positive or indeterminate, the sample should undergo confirmatory tests with a Western blot. So the next step is the Western blot test. This is the second step. So the purpose of Western blot tests is it is used as a confirmatory test to assess the presence of the specific antibodies against different proteins of the Borrelia burgdorferi. So the interpretation in IgM response, the IgM antibodies generally indicate a recent infection, but their presence isn't significant unless the symptoms have been present for less than 30 days due to the potential for false positives. And in the IgG response, IgG antibodies typically develop within 2 to 6 weeks post-infection and can persist for months or years, which complicates interpretation in cases where a patient previously had Lyme disease. Now let's move on to the treatment of the Lyme disease that will be discussed by the next reporter.
Hello everyone, I am Kylie, and today I will be discussing the different treatment and prevention of Lyme disease. So first and foremost, when we are deciding on a treatment after a tick bite, there are several factors that we need to consider, and on your screen you can see there are numerous. So first, we have to consider the likelihood that the tick carried the bacteria. Second, we have also to consider the length of time that the tick was attached, since the longer it is attached, the higher the risk of infection. There's also the possibility of the disease developing without the classic rash. The fourth one is we also have to consider the potential for serious long-term complication, as well as the reliability of antibody testing, and as well as the effectiveness and side effects of different antibiotics. And other important considerations include the patient's anxiety, willingness to follow up, overall health, and as well as even the cost of treatment strategies. Now, when it comes to antibiotics, a single 200 milligrams dose of doxycycline given within 72 hours of removing a tick has been shown to prevent the onset of Lyme disease in some cases. However, it's not always effective, and full treatment may be necessary. For actual Lyme disease cases, there are numerous antibiotics that are used for treatment. So first, we have the tetracyclines like the doxycycline and minocycline, which are commonly used, but they need high blood levels to be fully effective. The second one is the penicillins, such as the amoxicillin, which are more effective than penicillin 5 and are often combined with probenecid to maintain higher blood levels. In more advanced cases, or if other treatments fail, the third generation cephalosporins like ceftriaxone are considered the most effective. Cefuroxime, a second generation cephalosporin, is also helpful for atypical cases, but it is not a first-line drug due to its side effects and cost. And lastly, we have the macrolides, which are not recommended as first-line therapy for early Lyme disease because they are less effective. So next for the treatment are the special cases needing full treatment. So listed here are the tick when it is identified as Ixodes scapularis, nymph or adult. The next special case is when the attachment time is longer than 36 hours. Third is treatment can begin within 72 hours. The fourth special case needing full treatment is when the area is greater than 20% of the infection rate in ticks. The fifth one is the doxycycline is not contraindicated. And the last one is the neuroborreliosis. It requires intravenous antibiotics. Now, we can also observe persistent symptoms such as some patients experience lingering symptoms despite the treatment, and intravenous and oral antibiotics beyond standard durations, for example, more than 90 days, did not show any improvement over placebo in trials. Moving on to our last topic under Lyme disease, we have the prevention. When we are spending time outdoors, especially in wooded or grassy areas, there are simple but very effective precautions to follow. First is to check your body daily for ticks, especially after outdoor activities. Second is to wear light colored clothing so that ticks are easier to spot. Third, tuck pons into your socks to prevent ticks from reaching your skin. Fourth, although there was once a vaccine called Lyme, it was withdrawn from the market in 2002. Currently, no human vaccine is available, though a veterinary vaccine does exist, and there are new vaccine candidates under development. To summarize, while Lyme disease can be serious, early detection and proper antibiotic treatment are highly effective, and preventive measures play a critical role in reducing the risk of infection. I hope you learned a lot from our group. Thank you for watching.